Welcome to our review of hemorrhagic shock. My name is Edward Kelly. I'm an assistant professor in the Department of Surgery at Brigham and Women's Hospital, an affiliate of the Harvard Medical School. There are no financial interests or participation in health-related entities in any of the material presented in this set of slides. To begin with, we're going to review normal physiology of homeostasis with respect to volume and hypovolemia. We'll review shock physiology with special attention to mechanisms of compensation and how to recognize decompensated shock. We'll also review resuscitation with respect to the ebb and flow phases of shock. To begin, normal fluid physiology consists of, for a stereotypical 70-kilogram man, a 28-liter fluid compartment that is contained within cells and is highly regulated. The extracellular fluid comprises about 14 liters of total body fluid, and that extracellular fluid compartment is divided into a 3-liter plasma compartment, which includes both a 2-liter red cell volume, which is equal to the blood volume. In addition to the circulating blood volume, there is an 11-liter interstitial fluid volume, which consists of two phases: the gel phase, which is soluble collagen and mucoproteins, and the sol phase, which is small molecules in a thinner solution. The total blood volume, referred to in the previous slide, makes up about 7 to 8% of body weight, depending on age and gender. This consists of both fluid and cellular components in continuous equilibrium with the interstitial fluid volume compartment. This is indirectly in equilibrium with the intracellular volume compartment, which is again highly regulated. Hemorrhagic shock results from the loss of blood leading to inadequate perfusion of the organs. This contracted blood volume makes inefficient preload and unable to support normal cardiac output. Therefore, this shock state is characterized by inadequate perfusion, inadequate cardiac output, resulting in organ dysfunction and then ultimately organ failure and potentially death of tissues and organs and the entire organism if sustained. Hemorrhagic shock may be classified into 4 levels of severity. The scheme shown here is adapted from the American College of Surgeons Manual on Acute Trauma Life-Saving in the 9th edition. The least severe form of shock, or class 1, shown here, is associated with less than 15% loss of circulating blood volume, and in a normal adult, this consists of about 750 cc's or less of shed blood. The physiologic changes associated with this shock state are somewhat subtle. The heart rate is usually less than 100 beats per minute, again in a person without cardiac disease. Resting blood pressure and urinary output are both normal, and the level of consciousness is usually described as anxious but not impaired. With further blood loss, up to 30% of the circulating blood volume, or up to 1,500 cc's of raw volume, is characterized by the second class, or class 2 of shock. Here, resting heart rate is elevated above 100 beats per minute. Blood pressure and urinary output are still normal, but the level of consciousness can be described as agitated, but still oriented. In class 3 shock, or up to 40% of circulating blood volume lost, or up to 2 liters in raw volume, resting heart rate is extremely tachycardic. Blood pressure is characterized as orthostatic hypotension. The patient is frankly oliguric, and the mental status is confused. Beyond 2 liters passes into class 4, or most severe shock, with loss of greater than 40% of the blood volume and resting tachycardia, hypotension, anuria, and lethargy. The mechanisms of compensation are in play as these shock states develop and are compensatory to maintain homeostasis in class 1 and class 2 shock. The primary method of compensation in humans is vasoconstriction, which leads to a redistribution of blood volume to maintain flow to the vital organs, including the brain and heart, as well as to maintain core body temperature, oftentimes at the expense of peripheral temperature and peripheral organ perfusion. Vasoconstriction leads to an elevated vascular resistance and a redistribution of flow away from the skin, the muscle, the intestine, and the kidney, and again back to the brain and heart. Vasoconstriction on the venous side leads to decreased capacitance of the venous reservoirs and preserves venous return, again in an effort to maintain preload. Vasoconstriction and compensation are mediated by several neurohumoral mechanisms. This includes the elaboration of norepinephrine and epinephrine, as well as from adrenal sources, as well as from the postsynaptic membrane. Most of this is triggered through the carotid baroreceptors, as well as the atrial volume receptor, which leads to the elaboration of atrial natriuretic peptide inhibition. There is also endothelin-1 release from the endothelium that leads to further vasoconstriction, and some experimental evidence has shown that macrophages can release endothelin-1 under certain circumstances. There are endocrine mechanisms of compensation mediated primarily by cortisol, angiotensin, and aldosterone. Cortisol, elaborated by the adrenal cortex, produces hyperglycemia and insulin resistance in hemorrhagic shock states. Angiotensin again contributes to vasoconstriction, and aldosterone leads to solute retention, again in an effort to preserve circulating blood volume. Furthermore, there is elaboration of growth hormone and glucagon, further contributing to hyperglycemia and insulin resistance, but also maintaining compensatory vasoconstriction. And finally, vasopressin, elaborated in the circulation, produces vasoconstriction, especially in the splanchnic beds, as well as free water retention, again in an effort to conserve circulating volume. We'll now review the normal physiology of the interstitial space. The plasma contains approximately 139 grams of human albumin in an adult. The interstitium contains approximately 165 grams of albumin, and there is 10 grams of albumin per hour flowing freely from the interstitial space to the plasma compartment and back again. As we mentioned earlier, the gel phase of the extracellular compartment consists of a mucoprotein matrix, which is in a coiled tertiary configuration, and that affects the flux of albumin and solutes into the interstitial space. This is frequently described as trapping of albumin in the coiled state. During hemorrhage, the first phase involves activation of the compensatory mechanisms. In phase 2, there's a fluid sequestration or ebb phase, which is proportional to the severity of the shock. Phase 3 is described as the flow phase, where there is mobilization of fluid out of the sequestered beds in the interstitium, leading to diuresis of excess fluid. During phase 1 of shock, vasoconstriction and compensation reduces capillary hydrostatic pressure. In response, the interstitium contracts via coiling up of the mucoproteins, and intracellular fluid volume increases. This is the phenomenon of vascular refilling from the interstitium. The interstitial compartment decreases in an effort to maintain the homeostasis of the circulating fluid volume. This lasts until the hemorrhage is stopped. If a resuscitation is encountered, you see phase 2, where the interstitium expands markedly by uncoiling in order to again refill the interstitial space. Plasma albumin is trapped in matrix mucoproteins, leading to expansion or relative expansion of the interstitial space. This is at the expense of the circulating albumin in the plasma, so total plasma albumin drops precipitously, and albumin flux actually decreases by 60%. This state is characterized by a persistent oliguria while the interstitial space is expanded. After resuscitation and normal homeostasis again comes back, the mucoprotein matrix gradually returns to its coiled state. This leads to a contraction of the interstitial space and then an increase in albumin flux out of the interstitial space and back into circulation. This is associated with a fluid and solute diuresis, wherein the blood volume may actually expand, resulting in hypertension and some pulmonary dysfunction. Decompensation occurs when the loss of circulating blood volume goes beyond the capacity of the neurohumoral and neuroendocrine mechanisms, as well as fluid redistribution mechanisms, and the organism can no longer maintain normal perfusion of the vital organs. This results in dysfunction of the end organs that are on the losing end of redistribution of perfusion. This leads to the elaboration of lactate, reactive oxygen species, and other inflammatory mediators and danger-associated molecular markers. On the physiologic level, decompensated hemorrhagic shock is characterized by loss of core body temperature and heat. This occurs as a result of loss of body temperature blood and evaporative losses as well as radiative losses. This leads to total body hypothermia. There is also a decrease in aerobic metabolism as the perfusion can no longer maintain oxygen delivery, and the development of metabolic acidosis in those shocked organ beds. The acidosis and hypothermia is also associated with a coagulopathy, which is independent of the other two features, but is also often directly related to consumption of clotting factors in the face of ongoing bleeding. Anaerobic energy production in the shocked organ beds leads to accumulation of hydrogen ion and lactate in a hypoxic environment. It is best to remember, however, though, that blood pH and blood oxygen saturation don't reflect tissue perfusion, and that tissue pH and tissue oxygen tension don't reflect the intracellular compartments. Lactate produced during hypoperfusion in the cells will eventually make its way into the circulation, however, and the peak level and duration of the elevation of lactate correlates with the degree and severity of hemorrhagic shock, as well as predicts survivorship with resuscitation. A persistent elevation of lactate in the face of resuscitation indicates uncompensated shock or an ongoing loss that has been unaccounted for. The recommendations for acute resuscitation are shown here. For Class 1 shock, resuscitation with crystalloid solutions is effective in restoring normal homeostasis, provided there is no ongoing source of hemorrhage. For Class 2 or higher shock, resuscitation with crystalloid is ineffective in restoring normal homeostasis, and blood products must be used. Military experience has shown that a 1-to-1 ratio of red blood cells and fresh frozen plasma is superior to other ratios of blood products. Fluid volume resuscitation must be achieved concurrently with arresting ongoing hemorrhage. Coagulation defects appear early in severe shock. However, the traditional markers such as prothrombin, partial thromboplastin time, and platelet count are insensitive to shock-related coagulopathy. Thromboelastography, or TEG, has been shown to be more revealing for acute coagulopathy related to hemorrhage. And this modality can reveal both clotting defects as well as hypercoagulability. For this reason, concurrent recommendations for massive bleeding call for equal volume of packed red blood cells and blood plasma. Tranexamic acid is an antifibrinolytic drug that is used to prevent cleavage of plasminogen into plasmin. This is in widespread use for certain fibrinolytic states such as cardiac surgery. It has been proven effective in decreasing blood loss and improving survival in traumatic hemorrhagic shock in randomized controlled trials of massive bleeding. In less than massive bleeding, the use of this medication still remains investigational. It must be remembered that acute resuscitation requires reliable intravenous access. This generally is recommended as 2 large bore peripheral intravenous catheters, or perhaps an 8 French central venous catheter. Peripheral intravenous catheters smaller than 18 gauge, triple lumen central venous line, and PICC catheters are not acceptable for resuscitation from hemorrhagic shock. To review the interstitial space expansion in the third space, this coincides with the tissue acidosis and free radical formation and results from the mucoprotein uncoiling and the trapping of the albumin and solutes. This does increase the ability of tissue to buffer or tolerate acidosis, due to the expanded volume and the buffering nature of the uncoiled mucoproteins. The third spacing, or expansion of the interstitial volume, persists until the mucoproteins can be reconfigured into the coiled state. This may persist for days, however, and during this time, the patient is vulnerable to infection due to compromised barriers and compromised chemotaxis resulting from the fluid volume expansion. In summary, hemorrhage causes a predictable physiologic compensatory response from endocrine, neurological, and immune systems. Physiologic compensation is characterized by vasoconstriction, tachycardia, hyperglycemia, and oliguria. Hemorrhagic shock causes cells to accumulate activated oxygen species, lactate, and other mediators of inflammation. The interstitial fluid space expands in response to resuscitation, and it contracts as normal physiologic homeostasis returns. Serum lactate correlates to mortality in hemorrhagic shock. Blood products are required for severe hemorrhagic shock, and the recommended resuscitation for severe hemorrhagic shock is an equal ratio of red blood cells and fluid plasma. We'll now review the review questions. First question, what percent of total blood volume loss is correlated with orthostatic hypotension? 20%, 25%, 30%, or 35%? The answer is D, 35%. Orthostatic hypotension characterizes class 3 hemorrhagic shock, which results from the loss of greater than 30% of circulating blood volume, but less than 40% of circulating blood volume loss. And this class of hemorrhagic shock is associated with resting hypotension. Question 2. Which biochemical marker predicts mortality from hemorrhagic shock? A, lactate, B, base excess, C, pH, or D, anion gap? The answer is A, lactate. In prospective randomized human trials, persistent elevation of blood lactate predicts increased mortality from hemorrhagic shock. While other markers listed are associated with acidosis, they have not been demonstrated to predict mortality with accuracy. Question 3. What is the earliest laboratory marker of hemorrhage-related coagulopathy? A, fibrinogen, B, abnormal thromboelastogram, C, platelet count, or D, elevated D dimer? B, abnormal thromboelastography. TEG has been shown to reveal abnormal clotting in early hemorrhagic shock before the other markers.